Thanks, Maria.
Hi. Stephen, it's Alex Lyon here. Can you hear me?
I sure can. Good morning, Alex, or good afternoon. Thanks for joining as well.
Thank you very much, Stephen. So thank you for inviting us to host and present this month's webinar. And we've got a really interesting case, but there's some parts to this I wanted to introduce before we start, and then I'll introduce Sol, who's our current clinical fellow in cardio-oncology in London.
Great.
So this is a particularly special patient of mine for several years, as you will hear. I want to quickly ask, is Margot Davis on the line? And if she is, could she unmute herself and say hello?
I don't see her.
Okay, so this starts and has a strong international cardio-oncology society link, because many of the people on the line will know that in 2016, the ICOS Congress was hosted in Vancouver in Canada, and Margot Davis was one of the co-hosts who organized and hosted that ICOS 2016. And I hosted ICOS 2017 in London, and therefore I was invited to be on the ICOS 2016 organizing committee, really in an observer role, so I could see what was happening. So I got to meet people. And as you will see, that became a very critical connection, because it was Margot who first looked after this case in Vancouver, and then the lady, when she got repatriated back to the UK and lived near London, came up to my cardio-oncology service, and then we've been looking after her since then. So, and later on, I'll tell you now what the patient is doing in contributing to cardio-oncology advocacy. And the final thing to say is I've just come off the phone with the patient, and first of all, she consented to be us to share her case and gave me some very exciting new updates that I'll tell you about a little later. And the second thing is I've forwarded her the link and welcomed her to join if she is able to. So, so I just want to highlight that also to the audience, that the patient this case revolves around will potentially be joining this webinar. So
Great.
I'm going
to Margot is on the call now.
Okay, hello Margot. Do you want to quickly unmute yourself so we know you're there?
Yes, good morning. Can you hear me?
Yeah, what time is it with you in Vancouver?
It's 6 a.m.
6 a.m. Thank you for getting up so early, unless your kids have already got you up. Did you hear my introduction and the fact that...
Sorry, go ahead.
I was going to say, I just made the introduction that this case and the care that she received was coordinated partly because of us meeting each other through the ICOS 2016 organizing committee, and obviously when you hosted ICOS 2016 in Vancouver.
Exactly. So have I missed any of the actual patient presentation, or were we just going to get started?
No, we're just about to start, and Margot Krina is potentially going to join the webinar. Okay,
Wonderful.
So I've sent her the link. So I'm going to now hand over to our fantastic cardio-oncology fellow, Sol Andres. Now, Sol is a consultant cardiologist from Buenos Aires in Argentina, and actually before she came to us was running an outpatient cardiology service for Argentina's largest oncology hospital. So in essence, she had sort of found her way to doing cardio-oncology locally, and has been with us now for a year, and hopefully will stay for a lot longer. So I'm going to hand over to Sol to present this case.
Hello everyone, thank you Alex for the presentation, and thank you for the invitation. I'm thrilled to be participating here and presenting this case. As Alex said, I'm from Argentina and currently living in London and working with Alex Lyon at the Royal Brompton. So this case I'm going to present, which is a case of a patient with cardiotoxicity, but she was a low-risk patient. And this is usually the cases that surprise us. So I think that it not only surprised us, but it will surprise you as well. So she's a 35-year-old lady who was referred to the Royal Brompton Hospital's cardio-oncology service in August 2016. But 3 years before that, in 2013, she had a diagnosis of left breast cancer when she was 32 years old. And this breast cancer was ER positive, PR negative, and HER2 negative. So it was treated with left mastectomy, followed by adjuvant epirubicin, cyclophosphamide, and paclitaxel, and also received adjuvant radiotherapy with heart-sparing protocol. She had no history of cardiovascular disease or cardiovascular risk factors. She was a non-smoker. She didn't have any history of drug abuse, hypertension, or diabetes. In her family, her father had a heart issue, but she had lost touch with him, and her maternal grandmother had been treated or was treated with carvedilol at the age of 60, but we didn't have any further information regarding that. And we did know that she was previously fit and well. Actually, in September 2015, almost a year before she first came to us, she completed a 27-mile walk for charity. But in July 2016, and this is what Alex was mentioning, she presents with heart failure in Vancouver, Canada, while she was on holiday with her husband. She had been feeling weak for a few days and had a cough for which she had been treated, but she had no convincing flu-like symptoms and ended up admitted due to worsening shortness of breath and orthopnea. She was also treated for a possible pneumonia and eventually diagnosed with pulmonary edema and cardiogenic shock. Of course, when admitted, she had an echocardiogram, and this showed that her LV was severely impaired and the ejection fraction was lower than 20%. It was dilated. She also had moderate to severe mitral regurgitation, but the right ventricle was normal, and the rest of the valves were also normal. They performed a myocardial perfusion scan, and this was also normal, and she also had a CT PA that ruled out pulmonary embolism. So she was discharged with the heart failure medication that was available at the moment, carvedilol, losartan, spironolactone, and furosemide. And she then flew back to London. On the flight, she remained stable with no significant problems. But when first reviewed here in London, she was still symptomatic with exertional dyspnea, but she didn't have any symptoms at rest. And on her clinical examination, she was found to have a heart rate of 79 beats per minute, already on carvedilol, and her blood pressure was on the low side, so around 95.
No, ¿qué pasó?
And she didn't have any signs of fluid retention. The chest was clear and the heart sounds were also normal, but she did report symptomatic episodes of hypertension with frequent dizziness in the context of being treated with low-dose losartan and carvedilol. So this is the ECG that was first performed in this review, where we can see that she was on sinus rhythm at with a heart rate of around 78 beats per minute, with left axis deviation and rather small R waves on the precordial leads from B1 to B4. And this is the echocardiogram that we performed on the first review. And here we can see that her left ventricle is clearly dilated, and she has global hypokinesia, and this can be seen from the long axis and the short axis, but her valves, the aortic and the mitral valve, look rather normal in structure. And the RV also looks normal in size, at least from these views. Here we see from the apical views, and this confirms the global hypokinesia of the LV and the severe systolic impairment. And from these views, the left atrium looks normal in size. And regarding her diastolic function, this was moderately impaired. This is the report. So the LVEF was reported as 25 to 30%. Her LV was dilated, but the right ventricle was normal in function and dimension, and the heart valves were also normal in structure and function. And this is her blood tests, where we can see that the NT-proBNP was elevated, but the troponin was normal. Hemoglobin was also reduced, but the creatinine was increased, so she had kidney failure with an eGFR of 44. All the rest of the electrolytes were all normal, and her ferritin was a little bit reduced. Other tests like HIV and immune screen tests were performed, and this all came back normal. And the 24-hour Holter monitor that showed that she was on sinus rhythm throughout, with a mean heart rate at 81 beats per minute, confirming what we had seen on the physical examination and the ECG. And she had ventricular ectopics, and no significant bradycardias. So, after having performed the echocardiogram and the Holter monitor and the ECG, she underwent a cardiac magnetic resonance, and this was performed as well in August 2016. And we can see from the cine images that the patient has these images confirm what we have seen in the echocardiogram, where we see that the left ventricle is dilated, it's globally hypokinetic, and the systolic function is severely impaired. The valves, here we can see the mitral valve and the tricuspid valve, they seem to be preserved in structure and function. And of course, this was done with late gadolinium encasement, and we saw that there was a mid-wall fibrosis in the infraseptal basal segments, but there were no signs or no patterns of infarction or no evidence suggesting inflammation or edema, and the LV was also reported to be around 25% of ejection fraction. So she was treated. She was already treated. She had been treated in Vancouver when she was first admitted, and because she was still having some symptoms and exertion, but the titration of the medication was not so easy because of the symptomatic hypertension. Some changes in the medication were done. So, for example, we changed the spironolactone to a eplerenone, and this is something that's usually done in our service in patients who are ER positive. And ibabradine was started on top of the carvedilol to better control the heart rate. If you can remember, heart rate was around 80 beats per minute, and the carvedilol was not. We were not able to increase the carvedilol anymore because of her symptoms, and she was still symptomatic. So some ibabradine was added. So of course, she was recommended to do some gentle exercise, and she was referred to a local heart failure nurse specialist and local cardiac rehabilitation center. And this is how she progressed afterwards. September 2016, her heart rate was much better, was under much better control. We can see that it was around 60 beats per minute, and blood pressure was still a little bit on the low side. Eplerenone was increased to 50 milligrams OD, and losartan was switched to candesartan with a planned titration, but she was intolerant to drug titration. Unfortunately, the candesartan we were not able to increase it more than 12 milligrams because she was feeling weak and dizzy. But this improved a lot after weaning her of the furosemide. So now she was feeling stronger, and the echocardiogram confirmed not only what her symptoms were manifesting. The LVEF had now increased from 25% to 43%. Finally, in January 2017, when she came to the outpatient clinic, she had practically no more symptoms, and she was on carvedilol 6.25 twice a day, candesartan 12 milligrams once a day, eplerenone 50 milligrams once a day, and ivabradine. Her heart rate and her blood pressure were much better, and her NT-proBNP had reduced significantly. But of course, what was more significant was the change in the left ventricular ejection fraction, which now we could see a change from 25% on her first assessment to 50%, so almost normal. And so at this point, the plan was only to continue current treatment, no further changes, and cardiac rehabilitation program. And of course, bear in mind that this is January 2017. We had no idea about DAPA, empagliflozin, or whatever other medications we are or now know about. And this is the echocardiogram. And here we can see the very impressive change in her systolic function. And the LV is less dilated, and it contracts much better than the one compared, if you can see the one from August 2016. And this is a chart that shows the changes of her ejection fraction over time and according to changes in the medication. So the initial presentation was in July or June 2016. Of course, she did not have any medication for heart failure at this point, and her left ventricular ejection fraction was lower than 20%. And then she was then treated with the regular medication. At some point, she was started on ivabradine, and furosemide was weaned, and eventually her ejection fraction increased up to over 50%. And something very similar happened with the diastolic and systolic diameters and the presence of mitral regurgitation, which was almost none in the last echocardiograms. And this is the latest update that we have. Her in September 2019, she had an echocardiogram where her ejection fraction was found to be normal now, 55%, and in 2019, 69%. So this is a very unfortunate story with a fortunate ending. And this is the patient. And Alex, do you want to tell us something about her?
Thank you, Sol. So just to say, we're just having a short break because there's more to this case still to come. But Karina has been obviously come from a very difficult situation, first of all with a diagnosis of breast cancer as a young lady, and then within 2 to 3 years of treatment having very severe heart failure. And at the end, welcome Margot's comments on how her case was when she first presented to Margot in Vancouver, but was clearly extremely unwell, and then how she's responded. And I think it's one of my comments with this case is about the importance of tight heart rate control in people with anthracycline-induced cardiomyopathy or cardiotoxicity, because I think the high heart rate definitely is a metabolic stress. And then a couple of years ago, Karina contacted me to say some very special news, which is that through a surrogate mother her and her husband had a baby daughter. So, of course, having had an ER positive breast cancer, there may have been some concerns about pregnancy from an oncology perspective, and certainly from a cardiac perspective, given that history, I think she would be at a higher risk, although having recovered her heart function, one would hope she might be able to mitigate that, but the medication that she's requiring means that some of those would be contraindicated in pregnancy. So she and her husband made the decision to actually have a surrogate mother carry her baby daughter through to term. And so Karina has a lovely little girl. And I've just come off the phone with her earlier today, and she's just told me that a few weeks ago, she had a second surrogate pregnancy via a surrogate mother, and this time they've had triplet boys. So she's just had 3 sons born in the last few weeks. So their family has gone from 3 to 6 in one strike. But I think it shows a very informed and common sense approach to her complex situation. And one of the things that then Karina has kindly agreed to do is to be a patient advocate for cardio-oncology for the European Society of Cardiology. And I know she's been very active, and particularly now with hopefully some pressure on Brussels to release some of the funding which is ring-fenced for oncology back into a sort of cardio-oncology program and thinking of the late effects. So that's work in progress, but Karina's been, I think, fantastic as one of, I think, the world's first formal cardio-oncology patient advocates. And you can see the journey she's been on. So, however, the journey doesn't stop there. So I'm now going to hand back to Sol for the next part of her case.
Great, thank you, Alex. And wow, impressive. 4 kids. Now, so this is the summary. So she's a young lady with a previous history of right breast cancer, which had been treated with anthracyclines and radiotherapy. She did not have any cardiovascular risk factors. And yet, 3 years later, she presents with heart failure with reduced ejection fraction and a very severe presentation. So at this point, and I hope you agree with me, and if you don't, please let us know. We think that the most likely diagnosis is that she was having chemotherapy-related cardiotoxicity, and that we were in the presence of chemotherapy-induced cardiomyopathy. But let's play a game, and let's pretend this patient was not diagnosed in 2016, but in 2013, but in 2020 of her breast cancer, and that we are the oncologist or the cardio-oncologist, and that we have the opportunity to assess her risk of developing cardiac toxicity. And we now have this very practical and easy to use and evidence-based risk stratification tool, and this has been published in the European Heart Failure Journal, and this has been performed by the group of the Heart Failure Association of the ESC in combination with collaboration with the International Cardio-Oncology Society. And we can now assess her cardiovascular risk. And we know that she has no previous history of cardiovascular disease, heart failure, or severe valvular disease. She had not had any myocardial infarction. She didn't have stable angina or a history of LV dysfunction. We don't know her baseline biomarkers. Probably we wouldn't measure them, or maybe yes, but we don't know these patients. But we do know that she was not old, she didn't have hypertension, diabetes, or chronic kidney disease, and she had not been exposed to any cancer therapy before, neither anthracycline-based or non-anthracycline-based or radiotherapy. And regarding her lifestyle risk factors, she was a non-smoker, she had never smoked, and was not obese. So if we are the oncologist, we would say this is a low-risk patient. She doesn't need to be seen by the cardiologist. And if we are the cardio-oncologist or the cardiologist, we will say the same. She's a low-risk patient. She is fit to receive anthracycline chemotherapy, and the likelihood of her having any issues or any problems regarding her heart function is very low. So what happened? Well, we now get to know the mother. This is getting more interesting. And a few months later, after we met the daughter, our patient, we meet this 69-year-old lady with a history of rheumatoid arthritis who had been treated with methotrexate, and in this context had developed shortness of breath on exertion. So the rheumatologist and the pulmonologist think that this might be a possible adverse effect of the medication. So she's treated with steroids, but she does not respond very well to the treatment. And eventually she is admitted to another hospital in March 2017 with acute pulmonary edema. And the echocardiogram shows very similar findings to those of her daughters. She had a dilated LV with severe systolic dysfunction. Her ejection fraction was 20%. Her right ventricle was preserved in size and function, and she did not have any significant valve diseases. When she was first admitted, her troponins were elevated, so she underwent a coronary angiogram, and her coronary arteries were normal. Okay, she was then treated with heart failure treatment, and she responded very well. So now I have a mother and a daughter with similar disease, very different ages, and none of them had a specific cause for this cardiomyopathy, apart from the daughter having had received chemotherapy. So someone in the team thought that this might be related, somehow related, and they sent both the daughter and the mother to do a genetic assessment. And these are the findings. So both mother and daughter were found to have a missense mutation of a specific gene called BAG3. And this missense mutation caused one amino acid, the valine, to replace the phenylalanine and, from valine to phenylalanine. And although we know that BAG3 mutations, BAG3 gene mutations are a very well-known cause of dilated cardiomyopathy, these are usually the truncating mutations. So this particular mutation, this missense variation, had not been reported before, neither in the control population nor in the DCM population. So from a genetic perspective, this was classified of uncertain significance. Yet in the context of both patients having had dilated cardiomyopathy, developed dilated cardiomyopathy with no particular risk factors, and both having the same mutation, we think that it's more than of uncertain significance. But let's try to understand, and probably as me, most of you don't have a very good idea of what this gene is about. So the BAG3 gene is actually a gene that is located in chromosome 10. It codes for an anti-apoptotic protein that it is expressed in cardiac and skeletal muscle. And it acts as a cotoperon interacting with the heat shock proteins. And these proteins are released by the cell in response to stress. And their role is to stimulate the repair and degradation of protein aggregates that accumulate under stress. So we can now start to understand why maybe a mutation in the BAG3 gene plus a anthracycline or receiving a doxorubicin or epirubicin in this case may not be very well tolerated by the myocardium. So BAX3 is essential for normal production of filamine and modulates myocyte contraction. So knowing all of this, we can now understand why the BAX3 mutations are associated with dilated cardiomyopathy. And also, and this, as I said before, this is usually the truncating mutations, but also a missense mutation has been associated with hypertrophic and restricted cardiomyopathy and also myofibrillar myopathy. So there is evidence, and there's been published some specific data on BAX3 mutations and the development of dilated cardiomyopathy. So we have here a research article in which they proved that this was true in mice, and also a clinical trial done by a group in Spain, in which they proved that the presence of BAX3 mutation in 129 patients eventually developed, most of them eventually developed dilated cardiomyopathy, and a quite severe way of dilated cardiomyopathy, which presented at an early age. But again, this was mainly with the truncating mutations. So this is the mice models, and we can see that the fractional shortening, so which is surrogate of the ejection fraction, or another way of measuring the contractile function of the heart, for those who are not cardiologists in the audience, we can see that it decreases significantly over a period of time in the knockout mice compared to the control population. And also in the morphological and histological assessment, they could see that the knockout mice, the knockout for the BAX3 gene mice, had an enlarged heart with more fibrosis. So this is what we think that happened to our patient. She was born with a BAX3 missense mutation, which of course we didn't know about it. Then at the age of 32, she received anthracyclines, and this act as a second hit. And as a result of this combination, and this misfortunate combination, she had dilated cardiomyopathy at a young age. And so this was an earlier and more severe expression of the disease, because the mother had the same mutation, but she expressed it at the age of 69. So, do you have any questions, or anybody in the audience has any questions about the case or what I presented now about the genotype of these two patients?
Yeah, so Maria, this is a great presentation and a super fascinating case. I think that we have, partly because of our general interest in the diagnosis of amyloidosis, we have a very readily available setup to do genetic screening in patients that have some sort of cardiomyopathy. And so not all of my colleagues agree with this general approach, but I usually check all the available genes instead of just the TTR gene when we're looking for amyloidosis. So I'll check all the other genes to screen for. And what happens as a result of that is that you have people that have, heart failure or cardiomyopathy, and you do a genetic screen, and let's say you look for 120 different genes. You will find a number of people that have what you call a variant of unknown significance, or VUS. And that's basically what you have here. And what I have tried to do with the genetic company is to give the feedback that we have this patient that has the clinical manifestations of cardiomyopathy and heart failure, and they have this VUS that by definition means that it's not really associated with pathology.
Exactly.
But in your case, like this case that you're presenting, you're basically making the argument that that VUS is responsible for her susceptibility. And I mean, I have every reason to agree with you on this, because she had no other factors that would have explained, you know, this degree of toxicity. But how, and I don't know if you have any experience in this, but how can they, you know, ultimately change that VUS to be identified as a pathogenic mutation? And so the only way that you can do that I know of is making the connection to the genetic testing company that the clinical event is associated with that mutation, and therefore should raise the significance of that VUS to a pathogenic mutation. So do you have any idea whether this type of feedback was given to the genetic company, for example?
Alex, you know?
Dan, hello, Alex here. Great question, as always. And one thing I wanted to just say again to make the point is this lady had only 4 cycles of epirubicin containing chemotherapy with an EC75 protocol, which means the total dose of epirubicin was 300 milligrams per meter squared. Depending on which correction factor you do to doxorubicin, you might say 0.5 or 50%. So we're talking about a doxorubicin equivalent dose of about 150 milligrams per meter squared. So a young woman with no risk factors actually receiving a low dose of anthracycline. So, and yet having such a cardiac sensitivity to it to have such a profound heart failure syndrome. So that is one of the reasons. Now, when we get into VUS, as you know, it is complicated. Sometimes a VUS is stated to be one because it's never been reported before. So part of this is history. If you've got a mutation which has been reported in lots of people with a heart failure syndrome, whichever the phenotype is, and then you get that same mutation and the person's got a disease, it's called pathogenic. Whereas if you're the first person ever to have that mutation and you present with a heart failure syndrome, it's never called pathogenic. It's always called a VUS because they don't know how common that is in the healthy population without the disease. If you go back to the results slide, Sol, I know it's a few back, the devil is in the detail here. Now, let me just give you a background. This is actually the Brompton and Imperial College's developed cardiomyopathy panel. So what we study is 120 genes that are associated with cardiomyopathies, and I include in that electrical disorders of the heart. So there's SCN and the genes included for long QT syndromes and ryandine receptor, as well as those myofilament and titin and this lamin and BAG3. Now, if you look at both reports, at the bottom, it says that 87.5% of the modeling, because this is computer modeling in silico, would predict that this mutation would adversely affect the protein function. So one of the whole things with genetics is where is the gene mutation and the amino acid switch, and if it's a missense and you're not truncating protein, is it likely to affect the protein? Is it in a catalytic pocket or part of a critical folding position? So the fact that the modeling suggests this is likely to have a functional effect also raises the suspicion compared to let's say a mutation that was found to be in an area of the protein they thought was less likely. And if you look at the population controls, this mutation has not been found before. So whether it's the ESAC consortium or our own Brompton control population of healthy controls, so we're in a situation where this is a novel mutation. it's in 2 people who have presented with a dilated cardiomyopathy syndrome. And in the case of Krina, the daughter, our case, a very unusual situation in that the dose of anthracycline was so low, you wouldn't expect that to cause a degree of heart failure in somebody, and such severe heart failure. So finally, what our service does, because it is our panel, of course, is they do collect these, and I believe they get put into some international mutation database. So this isn't a commercial company, this is our hospital genetics service. And what of course needs to be known is if somebody else elsewhere in the world also has this mutation and also presents with a heart failure syndrome, that it's not called a VUS. But when you're the first one, I don't think you ever get called pathogenic unless it was a truncation and so clearly disruptive to the protein function. Dan, does that answer your question?
It does very well, but the you know, I think the next slide, or maybe the next slide after that, yeah, these you have 2 reports where the BAG3 gene was associated with disease.
Yeah.
So,
Yes.
you know, I think that, you know, the question is at what point or how do you give that feedback? Now, in your case, you can give your feedback to your hospital, and they can make the association between BAG3 gene and susceptibility to anthracycline toxicity, at least in this one person. But you know, maybe there are other people in the world that have also had this phenomenon, and you know, at some point you get a collective information that makes it a pathogenic gene.
So Dan, that is a perfect segue into the final part of our talk. So Sol's just got a few more slides for everybody, and then we'll open it again to discussion.
Exactly. So we are here, we have a patient with a BAG3 missense mutation, and then she receives chemotherapy. So we think that she develops a dilated cardiomyopathy at a young age, and probably due to these 2 events. So, but was this just a unfortunate coincidence? She had a mutation and she developed chemotherapy-related cardiomyopathy, or is there any association with genetics and genetic mutations and chemotherapy-related cardiac toxicity? So if we look into the classification of cardiomyopathies, and I'm sure you are all very familiar with this is the ESC position statement and of the classification of cardiomyopathies, in which these are classified into hypertrophic, dilated, ARVC, restricted, and classified, and then furtherly subclassified into familiar, genetic, or non-familiar. So where does the chemotherapy-induced cardiomyopathy fit in? So patients usually develop dilated cardiomyopathy, and this would be drugs fit into non-familiar cause of DCM, but our patient seems to have both familiar and a non-familiar trigger for the DCM. So again, is this just an unfortunate coincidence, or is this something that has some kind of relation or association? So there's this original research article that has been published in Circulation last year and of course, Alex Lyon is one of the authors, and Pablo Garcia Pavia from Spain is the main author of this article. And where they specifically assessed the genetic variants which were associated with cancer therapy-induced cardiomyopathy. So they were trying to answer our question. How did they do it? They included 213 patients from 3 different cohorts. So there were 99 adults with diverse cancers retrospectively recruited, 73 adults with breast cancer, and 41 children with acute myeloid leukemia, and these two last cohorts were prospectively phenotyped. They sequenced 9 pre-specified known cardiomyopathy genes, and the prevalence of these rare variants were compared between the cancer-induced cardiomyopathy cohort and cancer genome atlas participants, healthy volunteers, and another cohort of ancestry matched reference population. Then the clinical characteristics and outcomes were assessed and stratified by genotypes. And not only that, but they also assessed what happened in mice. So a prevalent CCM genotype was modeled in anthracycline-treated mice. So this is the baseline characteristics of the 3 cohorts that I mentioned with CCM, so chemotherapy-induced cardiomyopathy. And the most important piece of information of this slide is that comorbidities, cardiovascular risk factors were similar to the US population. Of course, in the first 2 cohorts, the cohort C, they are all children, so they are non-existent in this group of patients. And 90% of the patients received anthracyclines as part of their treatment. 30% received anti-HER2 as well, and the ejection fraction before the treatment was normal in the 3 cohorts. At the time of diagnosis of the chemotherapy-induced cardiomyopathy, the ejection fraction was lower in the cohort A, and this is something that it's reasonable and one would expect because this was a retrospectively analyzed cohort. So the time from chemotherapy to diagnosis was longer, and as you can see, the presentation was more severe as well. Now, analyzing the genes, so 9 genes were analyzed in all these patients. And if we go to the last row and focus on the general results, so all patients with CCM, with chemotherapy-induced cardiomyopathy, which were a total of 213, out of these 213, 26 had at least one mutation in one of these 9 genes that were studied. So 12.2% had one variation in one of these genes, compared to the healthy volunteers, which was present only in 3.4%. And this, if you go to the p-value comparisons, this was statistically significant. Of course, the most predominant and prevalent gene variation was in the titane, and this was the titane truncating variant, and which was present in 7.5% of all CCM patients, compared to 0.7% only in healthy volunteers. So, as the most predominant mutation was in TTN, they also focused in this variation, and then they then compared the adult cohorts, so the adult patients with CCM, with and without the mutation. And what was very impressive and interesting to see is that those with the mutation had a lower LVEF at the end. Atrial fibrillation was more prevalent, and heart failure related hospitalization was more frequent. So they had a more severe disease. And this was confirmed and by the mice modeling, where we can see that the fractional shortening over time was significantly reduced in those patients, those mice with the truncating variant of the titane gene, which were treated. So the red line is those with the mutation and treated with anthracycline, compared to the wild type and the untreated mice with the mutation. And this was also confirmed when they studied the isolated myocardiocite, and so the percentage of the sarcomere shortening was significantly reduced in the mice with the mutation and treated with anthracyclines, compared to those mice without the mutation but treated, and also to those mice with the mutation but not treated, and of course without the mutation and not treated. So the ones that performed the worst were those with the mutation and treated with anthracyclines. This was consistent with the data collected from the patients, so from the human beings. So these are the results, of the main ones, I think, is that patients with chemotherapy-induced cardiomyopathy had more protein-altering variants than comparative cohorts, so 12.5%, sorry, it's 12.2%, that's the type of all CCM had a gene mutation against 3.4 in healthy volunteers, and that adults with the chemotherapy-induced cardiomyopathy and the mutation had more heart failure, atrial fibrillation, and impaired myocardial recovery. And this was consistent with the information collected from the mice modeling. So what do the authors conclude? And most important part of this conclusion, I think, is that the genotype, along with cumulative chemotherapy dosage and traditional cardiovascular risk factors, improved the identification of patients who have cancer at high risk for CCM. But and another thing that they report, and this is in the discussion, is that despite the low prevalence of other variants, so not the Titan, but all the others, and if you remember in the first, in the graph that mentioned the 9 genes, BAG3 was one of them, their critical role in myocyte biology imply that variants identified here may contribute to an individual's risk for CCM. So this is what we think, and this that happened to our patient. So is this the future? Should we add the genotype and the risk score assessment of these patients? And now I would like to hear you.
Great, thank you, Sol. That was excellent. Maybe go back one slide and we can leave it on the new risk there. And so again, let's open it up to questions from the audience. And I might start by bringing in Margot, if she's still with us, to maybe comment on how Karina was and when she met her in Vancouver when she initially presented. Margot.
Hi. So yeah, so I think you've kind of sort of heard how she was, but she'd essentially gotten off a plane and presented to I think initially one of the smaller sort of peripheral hospitals with shortness of breath. I don't think I can share my screen with you. I could show you sort of her initial echo and her initial chest x-ray, but she was in florid pulmonary edema. She required high flow oxygen initially. And so she was worked up, of course, for PE because she'd just gotten off a plane, although her chest x-ray was really quite clearly pulmonary edema. And the CT chest really did just show pulmonary edema. So she was ultimately transferred over to us in our CCU. One of my colleagues had initially admitted her, and then I took over her care a day or two later, which was just really fortuitous because, you know, it became clear as we went through the sort of possible etiologies for this that the anthracycline really was the most likely cause. And with my interest in cardio-oncology and the fact that she needed follow-up in the UK when she went back, it worked out really well that I had been working with Alex on the GCOS planning committee. When she presented, she was certainly in class 4 heart failure, very dyspneic. She was tachycardic. She was normotensive, however, and her initial blood work was actually reasonably good. Lactate was normal. Her creatinine was, I think, in the 80s. BNP was sort of actually only mildly elevated, which was surprising for how sick she looked. And she responded really well to initial diuresis. She diuresed quite nicely, as Lasix naive patients often will. And so we were able to dry her out in a couple of days and get her initiated on sort of low doses of therapy. We were sort of cognizant about Karina's insurance coverage concerns, and so we didn't go crazy with investigations. We had talked about potentially doing an MRI, but it just didn't make sense to do that in Vancouver since it was probably not likely to change management. So we sort of ruled out ischemic cardiomyopathy and then just treated her for presumed anthracycline-based cardiomyopathy after that. And it's been wonderful over the years to hear from Alex how she's done and to hear how well she's recovered, to hear of her advocacy in cardio-oncology, and of course now to hear this amazing news about her family.
Yeah, really fantastic presentation and truly extraordinary story. Yeah, but I think Alex, you know, on your risk assessment diagram, which I think is very good in general, and it would, you know, if you do any sort of publication and you hope that it covers about 90 or 95% of all the clinical decisions that you have to make, then I would consider that highly successful. You know, if you're proposing that gene mutations be added to this risk assessment, that covers about the other 0.1% of possible causes. So I think that it's hard to imagine, at least at this point, that we would know what mutations to put there on your risk assessment tool.
Well, I agree, Dan. And the other thing we're all realistic to is that many people on this call are working in academic centres, university hospitals, but the vast majority of oncology care is delivered at smaller hospitals that won't have access to modern cardiomyopathy genetics. Although I think with the increasing interest from the oncologists in doing genetics, not just of the tumour, but of the sort of germline, that I could see in the future a possibility that the blood sample taken to do the oncology gene panel also includes the cardiomyopathy gene panel in a patient where you're considering anthracyclines or trastuzumab or other drugs that we know cause heart failure, providing you get the result in a clinically useful timeline. So if I really push my colleagues in the clinical genetics service, they can actually get the result of this cardiomyopathy panel back in 3 to 4 weeks. So yes, a patient would have started treatment, but you'd get maybe after cycle 2 and before cycle 3 the result of whether they've actually got a mutation. And I think this would be relevant only for the low risk patients at baseline, because it would change them, or the low and medium. Obviously, high-risk patients are high-risk patients in their own right and will have been hopefully reviewed, optimized, and be under close monitoring. But it's this sort of lady where, you know, for all the understandable reasons, nobody thought this was going to be a problem. Low total risk, total cumulative dose in a low-risk patient. But it's going to come down to cost, availability, and as you say, which genes. You know, do you do the 120 panel? Do you do the 9 panel? And the incidence was 12.2% of the people who got heart failure. I suppose what one really needs to now start doing prospectively is studying the rate of that in a low-risk cancer population to get a feel for how frequently this is an issue.
Alex, it's Margot again. I think it's, by the way, is a really fantastic presentation, and it's a really interesting side to the story, and it certainly makes a lot of sense. I think though that we have to be really careful though that, as you say, we do this in patients where it's going to change management, because there are of course implications to a patient and their family members for being identified as carrying one of these mutations from a sort of insurance standpoint. And then to Dan's point, that's why I don't order the whole panel on my amyloid patients. And so I think that we need to be certain that this is really going to have an impact on management before we do it, because otherwise you just have these sort of things hanging over a patient for the rest of their life that may or may not actually impact things.
I agree. I think there is a real world clinical decisional question that is always posed, and I think particularly by our younger patients, if they recover their ventricular function, asymptomatic, natriuretic peptides return to normal, which is, doctor, do I need to stay on these heart medications for the rest of my life? So we still don't know who can be weaned after they've had some cancer therapy-induced cardiomyopathy syndrome versus those who can't. We've obviously had the TREAD-HF study in a different population, sort of idiopathic dilated cardiomyopathy, where you guess genetics plays a strong role there as well. And it's interesting, that was of course run from the Brompton, so I know the authors and the data well, although I wasn't involved in the study. But it's how you interpret that data is interesting, because if you're the doctors like us, we're looking at it going, oh my goodness, you know, 46% of the patients relapsed when their heart failure therapy was withdrawn. That's terrible, we must keep everybody on their treatment. But the younger patients can read that data as well, doc. There's a 56 or 54% chance I can come off my medication safely, and I've got a long life ahead of me. Now,
Yeah, I would argue that one differently, because I imagine that, you know, when this patient presented in Vancouver and had life-threatening pulmonary edema, I imagine that she doesn't want to go back to that time.
Oh, I agree. I agree. So there's all those nuances.
If I was her, I would probably say, no chance. These medicines have made a huge difference, and I would not stop them under any circumstance.
So I agree with you, Dan, and I think the severity of the initial presentation for all these patients, whether it's chemotherapy related or even idiopathic and other causes, is very relevant, the severity. But in reality, we have lots of patients with, let's say, milder presentations where they still ask the same question. And I think in the future, it could well be that genetics will play a contributory role into whether you feel confident in a younger patient to withdraw their treatment, obviously with ongoing monitoring. And what we really need is a prospective study, a trial, to really answer the question and have the genotypes sort of prospectively within the study. Because I must admit, if you had a patient who you knew had a Titin truncation or a BAG3 truncation or another sort of mutation known to be associated with DCM, I would not ever advocate weaning their treatment. Whereas other groups, depending on severity, depending on other factors, presence or absence of late gadolinium on MRI is another factor. You could try and create a group we might call low risk, who you could then randomize to consider withdrawal of treatment. Again, for people in their 20s, 30s, 40s, where they've got the whole of their life still ahead of them. But we don't have the answers, do we, if we're being honest? So I think the safest process, sort of pathway of care at the moment is to keep people on treatment. And certainly for Krina, you know, we've agreed that this is the right strategy because of the genes and the severity of her presentation. But I think there is a question still to be answered in the wider group of cardio-oncology patients we look after who do have milder syndromes that then reverse remodel nicely.
Yeah, this has been a really fantastic presentation, and I greatly appreciate all the international participation. Has been super fantastic. And Maria, I'm so glad to see you doing well in London, and I know hopefully Alex will take care of you, and if he gives you any grief, you know, just let me know and
I'll let you know.
We'll straighten him out. But no, thank you all very much. We are over time, so we probably ought to sign off here pretty soon, but thank you very much for a fantastic presentation.
Thank you very much again for inviting us, and it was all the discussion was very interesting as well, so thank you, Alex, as well. and
Thank you
Margot
both.
participating.
Thank you all.
Bye, everyone.
Bye-bye.
Bye-bye from London.